Happy Friday, everybody. This is Dr. Peter Valenzuela, Chief Medical Officer for MMG. I'm here today with our guest, which is Dr. Ryan Nicholas. Ryan is our recently crowned Medical Director for Quality. So Ryan, thanks so much for being here with us. And I know it's going to be a hot weekend, so I hope you guys will stay hydrated and stay safe. Today we're actually going to be talking about something that's really timely for the group. Ryan, I know that recently we as a medical group went through what's called the CRO audit. Can you tell me a little bit more about what that is?
Sure. Peter, before COVID hit, Dignity Health was responding, actually Common Spirit Health was responding to the situation of the opioid crisis by gathering some information about prescribing patterns within its medical system. And that process was called the CRO audit. That involved collecting prescribing information about opioids and comparing them with national averages through Medicare. And that information that was collected was given to us back in 2019 to highlight some patterns of prescribing that have occurred within our group.
Sure. So what have we done with this information? Can you tell me how we've used this within our group?
Well, we looked at the information that was provided and we identified that there's a couple of interesting features to it. One is there's a broad range of prescribing patterns within our medical group, many of which are appropriate for the specialty and the circumstances, but because of the change over time in the standard of care for chronic pain management, some prescribing patterns don't fit with the current standard of care. So that was a useful piece of information for us to identify. Then as a group, our group leadership sat down and came up with some ideas on how we can standardize our group-wide expectation, because we have not historically set a standard for opioid prescribing in the ambulatory care setting. So part of our work here and part of our work in the QEIC committee was to come up with some updated opioid prescribing standards that we could share to give some guidance to our primary care providers.
Mm-hmm. Well, and we know why, this is really an important topic. Obviously, we have seen an increase in accidental overdoses and deaths related to opioid prescribing. We've also seen increased liability in lawsuits related to prescribing physicians. So, there's a patient care aspect and there's a physician protection aspect. So really appreciate the work you and the team have been doing this for this. So what does this require of our physicians and clinicians? What should we be doing to help protect ourselves?
Well, essentially what we're going to ask is we're going to provide our ambulatory care providers with a list of standard expectations we like everyone to live up to with the practice of medicine in the area of opioid prescribing. That's going to involve some consistent expectations. So you'll see in the slide coming up the upcoming opioid prescribing standards that are going to be put in place. I'd like to ask everyone, as you're practicing medicine, try and apply these to your practice to the best of your abilities. They're not complex, they're pretty straightforward. There's only 6 key points to start with here. And you'll see point number 1, there should be a minimum of 1 appointment every 12 months that's dedicated to the management of controlled substance prescriptions. And this should be designated as a controlled substance management appointment. So when we look for this in the chart, we'll be able to recognize it. It should only be scheduled with the primary care provider, that particular appointment, so that we know that the prescribing provider is the one driving the medical care in this case. Follow-up appointments should be scheduled every 3 months per standard practice according to recommendations from the CDC and the DEA and the California Board. But that may be with a APP provider if the PCP is not available for scheduling. The second point we'd like to highlight is that Narcan must be prescribed for all patients on a combination of both benzodiazepines in any amount. This is a state of California law, and if we're not living up to this expectation, we are at risk. So it doesn't require your patient to fill the prescription, but we have to document that we've provided that prescription, and that should stay in the medication list so we can verify and prove that we've done our due diligence. The third item, toxicology screening has been a question that we've had in the past. How often do I have to do this? What about chronically stable patients? Do I have to toxicology screen my 83-year-old patient on 1 Norco a day? And the answer is yes, we need to perform toxicology screening a minimum of once every 12 months on all patients on opiates. That is the new standard of care. And next point is a signed controlled substance contract will be documented in the chart for all patients on opiates over 90 days. That is just part of what we need to do to defend ourselves from liability in this environment. Lastly, or second to last, patients on over 50 morphine equivalents a day need to have documentation of discussion of risks, clearly documented plan, and a consideration of a pain management consultant documented in your notes. And that can be at that once a year controlled substance management appointment. Some providers may ask, how do I know how many morphine equivalents I'm prescribing or how many morphine equivalents other prescribers are putting into my patient's chart? Well, that's a good opportunity for you to take a look at the Cerner Controlled Substance Management tab, which we'll put up on the screen here. We've implemented in Cerner a view that lets you see the prescriptions currently active in your patient's med list. And it automatically calculates your morphine equivalents per day, which is really helpful, assuming you've updated your med list. So make sure that you take advantage of that. Also, on this page, you can document when you reviewed cures for each of these prescriptions, and you can find the date and documented presence of your opioid contract. Last but not least, on our opioid prescribing standards, going back to that first slide, patients on over 90 morphine equivalents a day need to be prescribed Narcan and a consult with an appropriate specialist for review and approval of the treatment plan. That has been strongly recommended by the CDC and the state of California. So that sums up our opiate prescribing standards, Peter.
Yeah, great points. Thanks so much, Ryan. So I guess my question is, how will we as a medical group be following up on this to making sure we're meeting these standards?
It's a good question. We are going to introduce the standards now, and then we're going to take a future review of the same data in about a 6-month look back and see how it's affected our levels of prescribing. And to do that, we need to have data that can be collected and documented to show the quality work that we're doing to protect our patients. So please make sure that you are documenting the good work that you do to provide appropriate evidence-based pain management services, because that's really what we need to be doing.
Sure, great point, Ryan. So what if our physicians and clinicians have questions? What do we do and where can we direct them?
There will be plenty of opportunities to ask questions. You can always email me through Gmail. You can reach out to department chairs Bianca Roberts and Jane Tsai, who have been excellent, amazing partners in this effort to try and streamline our opioid prescribing patterns.
Sure, great. Well, there you have it, guys. We are trying to make sure that we take care of the patients the right way. We're also trying to protect our group. And I think that if we can get our arms around how we better prescribe opioids and chronic pain medications, this will really take us a long way. So, Ryan, thank you so much for taking time to meet with me today.
Thanks, Peter.
And I look forward to seeing what comes next. And hope you guys have a great weekend. Thanks so much.
Enjoy the weekend.
Bye-bye.